So in this presentation, we're going to talk about clinical governance. Clinical governance is really very important and important for a whole number of ways within healthcare in general and also dentistry. But it's not something that's particularly well understood, particularly at this undergraduate level. So what I'm hoping to do today is that we can kind of demystify the subject a little bit, and we can explain what clinical governance is and break it down into what we call pillars. They're called the 7 pillars of clinical governance. They're basically into component parts to help you understand what each of those pillars are and how you can be involved in that as a therapist and what clinical governance means for us as clinicians, regardless of what field or what sector we end up working in. But before we move on to do that, I just want to explain a couple of these online resources to you. Healthcare Improvement Scotland, which is the first link that you can see there, that's the governing body, shall we say, for clinical governance in Scotland. There's an equivalent organisation in England, Wales and Northern Ireland, and they're called the Care Quality Commission. We are going to talk a wee bit more about those organisations in future lectures when we look at clinical governance regulation. But if you're looking for information and findings of clinical governance reports, publications, things like that are relevant to Scottish healthcare, then Healthcare Improvement Scotland is the place to go. The second link is to the Royal College of Nursing's resources to do with clinical governance, and in particular clinical governance in Scotland. It's quite a good website in that it puts in quite easy to understand language, and so you might well find that useful. And the last link there is to the Flying Start resources. Now, Flying Start is an educational website and resources that NHS Education for Scotland have. And there's lots of different modules you can do on there, but in particular this link takes you to the clinical governance section. There's some suggested reading, some activities to complete, all these type of things that will help you understanding of clinical governance as a topic. So if you're looking for any more information, then those are the places to go. So what is clinical governance then? Well, clinical governance is all about quality improvement. It's about making sure we're meeting the standards that have been set and aiming for higher. The quotation that I've got there, it came from what was then called NHS Quality Improvement Scotland in 2005 and is now moved on to be the Healthcare Improvement Scotland that we spoke about in the previous slide. So that it now encompasses not just the NHS, but all healthcare provided within Scotland. So that would include private care and things like that. And what they initially set out their definition of clinical governance to be was the systems through which organisations are accountable for continuously monitoring and improving the quality of care and services and safeguarding high standards of care and services. So, like I said, about quality improvement, making sure we're getting there. Safeguarding is a term that's used a lot these days, and it's not just about safeguarding our patients, but it's about safeguarding us as clinicians, about the reputation of the service, and all these sorts of things. So it is an absolute statutory requirement of all NHS health boards. They have to be involved with clinical governance, and registered healthcare professionals have to be part of that, of which, of course, we would include ourselves. So there's various different ways in which local health boards are involved and things that they have to do, and we're going to talk a lot more about this. But things like, for example, there have to be systems in place to implement and report on the quality of care that's provided. And that doesn't need to be anything complicated. You've all already been involved in that with your radiographs that you're taking. So quality assurance, you have to QA all your radiographs and give them all a grade, and that information is fed forward so that we can create an overall idea about the quality of radiographs. So things like that has to come from a health board level. The other thing that health boards have to do is they have to involve their staff and their patients and the general public in the quality improvement services and the consulting about making decisions, making publications and things. That has to involve the whole service and the service users and not just the management level. And probably the most important thing that aims to come from clinical governance is to establish this really supportive environment and to help people want to learn And by learning, we will improve the quality of care that we provide. So about supporting and enabling people to be involved in these processes. So the NHS quality improvement for Scotland at that stage had 3 factors that they wanted to focus on that would help us ensure that we were meeting clinical governance guidelines and therefore improving quality. And the 3 main components that they spoke about were clinical effectiveness, risk management, and patient focus and public involvement. And from there, we can go on to break those down a little bit more into these 7 pillars of clinical governance. And we'll talk about those and talk about each one individually, and that will help you understand. But to list them, we're looking at clinical effectiveness in research, which you'll see was one of the components that NHS Quality Improvement Scotland stated. Audit, which is something you've all done already. Risk management, education and training, patient focus and public involvement, using information and IT, and staffing and staff management. So let's go on and look at these all individually, and we'll explain a wee bit more, and hopefully it'll help you get a real good idea in your head of what clinical governance involves. So clinical effectiveness is defined as making sure that everything we do is designed to provide the best possible outcomes for our patients. So basically what we're talking about here is evidence-based dentistry. It's something we've spoken to you about since the very beginning of the course, and it's what we base all the treatment on. And this is one of the reasons why, because clinical governance says we need to do that. Obviously, we can't ensure the best quality possible of care if we're all just doing things because that worked for us yesterday, so we'll do it again today. There has to be a sound evidence base for it, and that's what clinical effectiveness and research says we have to do. We have to take an evidence-based approach to the management of patients, not just their disease, but the management of patients as a whole. And we need to be aware of developments and current guidelines so that we can make sure our practice reflects that. So that's our responsibility as clinicians, that we're aware of this new evidence, that we're aware of things like the guidelines for which we should work. So in our case, the SDCEP and the SIGN guidelines, and on a national basis, including the rest of the UK, obviously we've got NICE guidelines as well. We have to make sure we know those, and we have to make sure that we follow that and implement that into our day-to-day practice. Failure to do so means that we would fail to meet this pillar of clinical governance. The other thing that we could be involved in would be contributing to the research and developing the evidence that people are basing their treatment on. So that might be something that we choose to do, or it might be something that we're asked to provide. Sometimes when you're working out as a qualified clinician, you get survey packs that are sent to you from NES, or universities are conducting some research and they want you to provide them with evidence. Now, that isn't, it is voluntary obviously, and that you can just not send the research back, but it's important that we can provide that kind of information. That's where the research comes from which we can base our work. So it's about having that involvement as well at the grassroots level, or further up if that's what you choose to do. So this initial first pillar, clinical effectiveness and research, is all about evidence-based dentistry, and you know all about this already. So the links there to the website and for evidence-based dentistry and what it is, this won't be anything new to you, but it's relevant specifically to clinical governance, hence why we've added it in here. So the second pillar is audit. Now you're all at that hand at audit now. You've all done your audit, you've all completed 2 cycles of audit and received your grade and feedback and things. So you know what audit is. But what I want you to understand now is that audit is part of clinical governance. And unfortunately, this order of the lectures hasn't quite allowed us to highlight that yet. But it makes sense that audit is about monitoring and improving quality. That's the whole point, is that you want to see how something is at the moment and make it better. So therefore it fits very neatly into clinical governance. And it's something that actually dentists require to do as part of their registration. So in the same way as we do, and they have their CPD hours, a certain number of hours of verifiable, non-verifiable CPD that they need to do. In addition to that, dentists have a number of audit hours that they have to complete throughout their 5-year cycle. Now, at the moment that is just for dentists, although I fully expect that as the register changes and evolves, it will become something that we need to be involved in as well. And that's part of the reason why we get you to do the audit process whilst you're a student. If you can get to grips with it now, which you all have, then it'll be much easier for you in the future. So this diagram we've got here, I think, is a really good way of explaining the audit cycle and explaining how it's never ending. And that the whole purpose is to make things better. So obviously we've got to have a starting point and we've got to identify a problem or an issue or something that interests us, like you all did right at the beginning of semester 1 when you picked your audit topics. Then we need to move on to the next stage, which is about setting criteria and standards. And a lot of you will have found that when you got your feedback from your initial audit proposal, I said to you, so what evidence are you basing this on and what standards are you basing it on? So, for example, if it was an infection control based audit, there will be infection control standards that we need to meet. So you can't really just say with an audit, well, I want it to get to this standard. There needs to be an evidence base for that. So that's your second stage. Then we move on to data collection, and people often think that's the most important part of your audit. And you know, it certainly is a very important part because you can't analyse quality or analyse practice if you've no data in the first place. But it's actually moving on from there and comparing what you found from data collection to the standards that you've previously decided that's the key element. So this is what you did in the discussion part of your audits that you've done. You looked at what you'd found and then you looked at what it was supposed to be and you tried to come to some conclusions or some ideas as to why those two weren't meeting or were meeting if that had been the case. And then based on those discussions, you're then going to move to what they've got numbered as part 5 here, which is implementing change. And that is the whole key point of audit. If you can't implement a change to make it better, then the process of audit has no purpose. It's all very well finding out what something's like, but if you've not done anything to make it better, it's just been a data collection exercise and you've kind of stopped at point 4. But then once you've implemented change, you then need to keep going and you need to see if this change has worked, if it's been of any benefit. Maybe it's actually made it worse. There's times when you, with all good faith, decide, oh, that I'll make this change, it will definitely help, and actually it's a bit of a disaster. But unless you re-audit it, you'll never find out. So it's a constant cycle audit, and the idea is that at some point you get to the point where you're 100% meeting the standards that have been met. But by that point, you've probably got new standards that have come in. So it's rare that the audit process ever fully stops. Someone else might take over from you, but it's a constant cycle of quality assessment and improvement. Risk management is a really big part of clinical governance. And risk management and risk assessment is one of these things that sends dread into people. They think it's this terrible bureaucratic process and it just involves management and all this kind of stuff. But what I want to try and do is break it down a little bit and explain why it's important and why it can be relevant to us. So the idea of risk management is to implement robust systems to understand, monitor and minimise the risks to patients and also to staff. So in those moments when you think, oh, I'm doing a risk assessment and this is so not relevant and I'm so bored, just always have in your mind it's about minimising the risk to your patients but also to you. About assessing what we're doing and is it the right way. And it's how we try and stop people not receiving the best quality of care possible and not hurting ourselves as well. We have to learn from our mistakes. We all make mistakes. At work, you know, there's all been times where we've done something and we've gone, oh, that was silly, that didn't work. Maybe you genuinely didn't know that wasn't going to work. or that the outcome would be bad. Or maybe you kind of knew, but you just chose to ignore it. We all make mistakes and we have to learn from them. So therefore, we have to feel safe to admit the mistakes. And this is another way that clinical governance goes wrong sometimes. You'll all have heard probably the term whistleblower being used, and the mid-staffs report, the Francis report. Again, we're going to talk about that a wee bit more in future lectures. But one of the things that came out of that report was that people were too scared to say, I've done this wrong, or that person's doing it wrong. Because what they got from that wasn't productive feedback. They were worried that they would get in trouble. People were losing their jobs, particularly people who were trying to have conversations about someone else's practice that they felt wasn't up to scratch. They were being squeezed out and their jobs were no longer available to them. So in order to manage risk, we have to be able to openly talk about when things haven't gone to plan and when things haven't worked out well. Another important part of risk management is about compliance with protocols, like infection control, data protection, all these kind of things, and being able to log when protocol hasn't been followed. There's always times when things can't quite go to plan, but being able to make a log of non-compliance. Significant event analysis, I'm going to come on to talk about, and incident reporting. These are something, particularly incidents reporting, you probably remember speaking about it in first year in the regulation of dentistry, so we're just going to go into this a wee bit more. Complaint handling. Obviously, if we manage our risks well, then there will be less complaints. But when we do have complaints, we need to be able to handle them and learn from them. And lastly, the actual risk assessment process itself obviously falls within risk management. So if we look at significant event analysis, this is something that you can do with lots of different things. And it's something that we sort of do mentally anyway. When there's an incident, we think in our head, why did that happen? Why didn't it work out how I wanted, or why did it go particularly well? And what am I going to do about it? So it's just a formalising of that process, significant event analysis. And the questions we want to ask ourselves are what, where, when, who, and why. So what happened? What was the incident? Now, bearing in mind, significant event analysis should be done not only because at that time that you slipped and you banged your head. It could also be that time that you nearly slipped because the floor was wet, but you managed to stop yourself. So near misses as well. And also, if something's gone really well, if a patient compliments us, officially puts in, with those times when you get a wee letter from the patient to say, thank you very much, you've really helped me, blah, 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 all that kind of stuff. These are commendations, and you should be significant event analysing these as well. It doesn't have to be a bad thing. So, exactly what happened. Where it happened, in the dates and times, and who was involved. So that's your what, where, when, and who. And the really important bit is why. Why did that happen? And there's lots of questions within that you can ask. Why was the lid left off the sharps box so that it fell and emptied out onto the floor? Why was the floor wet and nobody had put a sign there? And that often involves talking to a lot of people. Sometimes significant event analysis is a really quick, straightforward process, and other times it takes more to it. And then, above everything else, the most important thing is what we've got on the slide here is prevention. It could also be reoccurrence if it was a good thing. You'd want that to happen again. But more often than not, we're looking at prevention. So how can we put a change in place to stop it happening again, or promote the incident in the case of a commendation? So it's kind of like a mini audit almost, rather than having a cycle that's gone on and you've maybe collected data over a period of time. You're just analysing that one event. And this diagram here is just giving us a wee representation of what I was explaining there about the cycle, what and who and when and why, and what you can do to help it stop happening again. And then moving on from there a little bit, we can look at incident reporting. Because incident reporting is basically a significant event analysis. I don't know if any of you will have had to do it or not, but if any of you filled in an IR1 or a DATIX form on the health board system, you'll be familiar with all those questions we've just been talking about in significant event analysis. They want to know exactly the details and who was there and who witnessed it and what time of the day it happened and what were the overall outcomes, and assigning an outcome to it and getting other people involved. So we have to report incidents, and you shouldn't be scared to report an incident, even if it was your fault. So, for example, a couple of months ago, I was treating a patient. I was doing some anterior composite work. I'd finished putting the composite in and I was polishing the composites, and I had a long tapered high-speed burr on my handpiece, and I picked it up and I used it and I put it down. And I put it down in the coupling, and I left the burr in the handpiece. And about 2 minutes later, I turned round, I moved my arm, and I scraped it all down the side of my arm. That was entirely my own fault. I had left the handpiece on there. I'd left the burr, in the handpiece. I'd left it available for me to scratch myself on, and more worryingly, available for the patient or my nurse to scratch myself on. So I was in the wrong. But I needed to report it. And because the environment that we have within this health board is supportive, I didn't feel scared to report it. I knew that I'd done wrong, I was going to learn from it. I certainly won't do it again because it was really sore. And I filled in an IR1 form. And you might think, well, what's the point? Okay, nobody else was affected, it was just me. My patient was a very low risk patient. I didn't feel the need to go to occupational health or anything like that. So why bother reporting it? Well, I need to report it because I need other people to not make that mistake that I made. And it's the same if you think, well, what's the problem? Why this not really got much of an issue if I don't tell anyone about that? So the example I put here is spillage of a cleaning material. So maybe the cleaners have come in, they've spilled something on the floor, they've cleaned it up, so it was fine. They'll just not tell anyone, because what's the harm done? But then maybe a couple of weeks later, that person starts to feel really unwell. Now, if that incident had been reported and we had all the details, we'd be able to go back to that and go, do you know what, this seems to correspond with when you started not feeling very well. Maybe there was something in that material, maybe you've had an adverse reaction to it, maybe it's some kind of delayed reaction. But if that incident was never reported because nobody thought it was important enough, we've not got that paper trail to go back to try and help support that member of staff who's obviously had an adverse outcome. So anything that doesn't follow protocol needs to have an incident report done. General practice tends to have an incident report book. Health boards, we now will use the DATIX system, which you should be very clear on how to access and how to complete. It's usually linked directly from your health board intranet page. And you want to include as much information as possible, because the more information you have, the more detail can be got from it, and the more that we will learn from the reporting of the incident in the first place. The next thing is complaints handling within risk management. There has to be a complaints policy. You can't just say, oh, well, the boss will deal with it. There has to be a written complaints policy. And by law, there's certain things that policy has to include. For example, you must acknowledge a complaint within 3 working days. That doesn't mean you have to have done anything about it, but you have to, once you've received that complaint from the patient, acknowledge it in writing to say, I've received your complaint, I'm looking into it. You then need to give a full report within 20 working days. Now, that's not long, that's a month, when you need to have investigated it and reported back. And that report must include anything you've done to prevent further complications if something happens. You are quite within your right to say, I have investigated this, and unfortunately I don't feel that there are any grounds for your complaint. That's fine as well. But you do have to investigate it and report back on it. So NHS Scotland have a policy called Can I Help You, which is the complaints handling policy for any practice that works within NHS Scotland. So that could be a general practitioner out in a high street practice, or it could be a salaried practitioner or whatever. If you have a contract with the health board, you have to meet that policy. And the image that we've got there, which is making a complaint about the NHS, is the leaflet that's given to patients in the event that they want to do that. And it's freely available. I mean, that's just from online that I found it there. So patients can access it really easily. And that's important as well. Just in the same way that we need to be able to voice our concerns about the service, the patients need to be able to tell us how they feel as well. Some people think having a leaflet like that about making a complaint about the NHS is actively encouraging complaints, and that's not its intention. Its intention is just to make people feel comfortable and be able to do it. Because we British are terrible at not making complaints. We'll moan and we will moan and moan, but when it actually comes down to it, will we actually do anything about it? It's like in a restaurant. You go out for your dinner, and if there's a lot of you, maybe say a group of 10, there'll be one person in that didn't really enjoy their dinner. And they'll keep telling you about how they didn't really enjoy their dinner for the next 3 days or 4 days. And if anybody ever suggests that they go to that restaurant again, like, oh no, it was dreadful, the food wasn't cooked, it was cold, whatever. But did they actually do anything about it at the time? Does that restaurant even know that there was a problem? Because we're dreadful for making complaints. So that leaflet there is not designed to encourage people to complain about nothing. It's just to make people feel comfortable to complain when they feel that they've been wronged in one way or another. And then the last part of risk management is the dreaded risk assessments. And I say the dreaded because people think it's just the most boring and awful thing to do. And, to be honest, I've done a few risk assessments in my time, and it's not the most fun I've ever had on a Friday afternoon. But it is a necessary process. So it is mandatory to complete a risk assessment for any new procedure or process or material or equipment, and they have to then be reviewed on an annual basis. It is a bit complex, and there's a whole host of detail that you have to include. But if these risk assessments aren't done, then it becomes very difficult to do the other parts of risk management. To do a significant event analysis for something that the service didn't even know you were doing because it's never been risk assessed, and it just causes a whole world of problems. So it's not normally something that would come to a general member of staff to do. It's generally people employed in this role of risk management, but they are done for anything new and then reviewed. There's a template available, and local health and safety departments have their own one. So if you have a look on the intranet for your individual health board, you'll be able to find that information about risk assessment and how to assign various different risks to things. And the National Reporting and Learning Service, if you Google that, they've also got a guide online to help support people complete risk assessment. It's a bit dry, but it is an important process, and it's something that you need to be aware of. It's all to do with risk management. So just to recap then, because risk management is quite a big part of clinical governance itself, within risk management we look at significant event analysis, incident reporting, handling of complaints, and also risk assessment. And all those things combine together to be able to manage the risks that we somewhat inevitably have to put ourselves under as employees. Moving on to the fourth pillar of clinical governance, this looks at education and training. And this is really all about continuous professional development. We know things change throughout our careers. Even just in the 2 years since you started the course, there's already been changes and developments. Things like the introduction of direct access, for example. So we have to make sure that we're continually up to date. Now, that's always been the case. But historically, the problem with education and training was that people in particular employees, didn't feel that they were able to do it. They maybe didn't feel supported to do their continuous professional development. They didn't feel able to ask for help. Maybe they didn't have the time because of their working hours or conditions. So this pillar of clinical governance aims to eliminate those barriers. And what it's looking to do is to provide encouragement and support to allow all staff to be competent and also develop their skills. So not just skills that are necessarily essential for the job, so mandatory training, but also to look to find ways to support staff who want to develop their careers to a higher stage, so we say. And it is essential for the entire team. So CPD is not just for us as clinicians, but also anybody who's on the General Dental Council register, for example. So that's dental nurses, dental technicians, hygienists. They all require to complete verifiable and general CPD, just as we do, as do anybody who is on the general medical profession, so doctors, nurses, specialists, allied health professions. So in order to comply with this area of clinical governance, we have to be able to do those things. Things like study leave. So all NHS employees are entitled to a certain amount of study leave, and paid study leave, that is. That may not be provided on a paid basis if you work in general practice, say, but you should still be entitled to that time off within your normal working hours, within reason, to complete mandatory CPD. Peer assessment and review is a really important part of education and training. Things like your staff meetings, whether that be sort of a weekly all-staff meeting, or a lot of practices or establishments will have, say, clinicians meetings once a month where we get together and discuss cases and get opinions on things. Even just maybe shadowing a colleague for a day, there's a lot to be learnt from doing that, both from you being the person who shadows and also from the person who's being shadowed. You can learn a lot from each other. Appraisals come within this pillar as well, and appraisals are really important. Usually they're annually, they could be more often than that, and it's where you sit down with a senior member of staff, it doesn't necessarily need to be your employer, and you look over how the year's gone, how you think you've performed well, and what you think you need help with. Maybe you've got a personal development plan that you're looking to work on, and appraisals are the time when you can discuss these things. People often get worried about appraisals and they think, oh no, this is the time when I'm going to be told everything I've done wrong throughout the year. That shouldn't really be what appraisals are about. Yes, if you need extra support for something, then that's going to be highlighted to you. But you'll often find that's something that you're going in with already yourself to say, I need you to help me with this. They're not a time for disciplining. If something's gone really wrong, that needs to be dealt with at the time and not all saved up for your appraisal. So shouldn't feel nervous about appraisals. It's a time for development. Within the Health Board, we have something called KSF, which is the Knowledge and Skills Framework. It's an online electronic programme that they use, but it's really just for appraisals. And then lastly, we could look at postgraduate training and examinations. For us as therapists, there's things that you might want to do, maybe develop your teaching skills. So for example, the internship that we run, that Mr. Thompson did and now Mr. Jackson's doing, it's a good opportunity to develop your skills on that front. And there's also general postgraduate things you can do, master's programmes, things like that. There's also membership of the Royal College of Surgeon exams and all these types of things. And although these things generally have a cost attached to them, and you would normally be looking to pay for that yourself, there should be time allowed within your working time for study leave for you to develop enough to be able to do these postgraduate programmes. Patient focus and public involvement is a relatively new introduction to clinical governance. It's one of the newer pillars. It's something that in this context I'm going to talk specifically in a Scottish context because it was in the context that we're referring to implemented by the Scottish Government, and it's all about the service users. So we can't really just call them patients, because we also need to think about patients' families and carers and things like that. So hence the patient and public involvement. And the aims of this were to provide a service where people feel respected and treated as individuals and have involvement in their own care. So people aren't just treated like a conveyor belt. They come in, they have their treatment and they go out. It shouldn't be like that. They should be able to feel like they can discuss their treatment options and have a say in what happens to them. Another aspect to this is that groups and communities are involved with improving the quality of care and influencing planning services. So a lot of that comes down to things like focus groups and involvement of the public in public forums and things like that. Open meetings as well for health boards where members of the public can come along and share their opinions or their grievances or hopefully commendations as well. The whole overall arch for this is to design a service by and for the users. So it's not just something that the management do and then people use it. They're all involved in the development. They have these things called national involvement events where people are invited to give their suggestions to how we can improve things. And also your local and national surveys. Some of you may have been asked to be part of this. Even sometimes maybe when you go to the GP, they will ask you when you leave, they'll say, I'm just completing a patient feedback survey. And that's part of this. And the patient questionnaires that you guys are asking your patients to complete as well, that's all part of us fulfilling our clinical governance obligation in the patient focus and public involvement pillar. So it's maybe not something that you would think about directly, but it's going on all the time and just making sure that the service users feel that they can be part of the development and not just on the receiving end. So the penultimate pillar is using information in IT. I'm not going to spend a long time talking about this. It's basically the Data Protection Act. Making sure that you keep full, accurate and contemporaneous clinical records. So not only is that a requirement of the General Dental Council and a requirement of our registration, but also from a clinical governance point of view, we must do that. And making sure that you're completing your notes at the time. Okay, they shouldn't be completed 24 hours later. They need to be completed on the day, preferably immediately after the appointment. And that you're checking them for accuracy. Now, when we're writing quickly, we're all prone to the odd typo. You really should go back and read your notes, whether it be immediately or perhaps it's something you do quickly at the end of the day before you leave, but they need to be accurate and not full of mistakes. Confidentiality protocols also come within this. So if you're passing data from one individual to another, making sure that you have patient consent for that. Like I said, compliance with Data Protection Act 1998, and that needs to be regardless of whether you're keeping electronic or paper records. It all needs to be compliant with that and making sure that it's secure. Patients have access to their medical records. They are able to access them anytime they want. You should always bear that in mind when you're writing your clinical notes. A patient could have a look at that and by all means make a complaint if they're not comfortable with the language that's being used, say, for example, in their notes. We're also legally obliged to make that data available in a suitable format for quality assurance, so for audit, say, for example. Now, obviously, things need to be anonymised in most circumstances, but we can't withhold information for audit purposes if it's something that's been asked of us. As long as it can be anonymised, we need to be able to provide that. So this pillar is very straightforward, and it's just making sure you follow all the guidelines that come with data protection and confidentiality rules, and something that really stems back to your regulation of dentistry that you covered in first year. And the last pillar talks about staffing and staff management. And this is to try and combat predominantly understaffing. Now, dental practices, general practices, they're small businesses. And having a full complement of staff is expensive and not always particularly easy. Maybe finding suitable staff is difficult, let alone paying them. But in order to comply with the staffing pillar of clinical governance, we have to say that we have appropriate recruitment and management of our staff. That we've got enough staff in order to be able to fulfil all the others. So if you think, for example, back to the education and professional development, you've got to have enough staff to allow people to do that. But also to make sure that our staff are managed properly, that we're looking at management of underperformance. So whether that be in the disciplinary procedure or if it's just a sort of gradual ticking thing, then the appraisal. And if we have a good management process where we motivate our staff and help them to develop and help them to grow, as well as make them feel comfortable with things like informing about underperformance of their own or anyone else's, then that helps us keep high levels of staff retention. For a patient, continuity of care is very important, and that's not just the dentist or the therapist that they see, but they like to see familiar faces. They like to see the same nurses or the same reception staff. And it doesn't reflect particularly well on a practice or an organisation. If you've got a turnover of staff every 6 months, it suggests that people don't like working there and that it's not a very nice place to be. So high levels of staff retention reflects really well on a practice, and it's something that it's worth asking about. Maybe if you're applying for a job somewhere, you usually get the opportunity to have a wee chat with members of staff. How long have you been here? Or do people stay a long time? Or do you get lots of coming and going? And that, if there is lots of coming and going, it would suggest that maybe the clinical governance procedures in general are not up to scratch. And just making sure we've generally got good working conditions. Happy staff equals a happy place to work. And that's really important. We spend most of our lives at work, and you don't want to be going to work and thinking, oh, I love what I do with patients, but yeah, I never get time to do my Learn Pro, or nobody listens to me when something's gone wrong. Happy staff, happy job, and it's the way forward. So I'm really hoping now that we've gone through and explained all those pillars of clinical governance, that you can see that it's more than just the role of management and that we all have a part to play in it. So as an individual, just you on your own, the things that you can do to make sure you're complying with clinical governance are things like identify your areas of weakness. And that can just be from thinking to yourself, oh, do you know what, I find that really difficult. Keeping a sort of reflective diary. Maybe it's not something you're going to write in every day, but something that you keep note of. Things that have gone well and why they went well, and things that haven't gone well and what maybe you could do about them. You can also, of course, speak with your colleagues to identify areas of weakness. Maybe not just you yourself, but as a group. And that's where peer review comes in really handy. And that's why we've been making you do all these peer review, both on clinic and peer assessment earlier in this module, because it is something that's really relevant for the future. And it's a really good way of making sure your performance is the best it can be. Evaluation of our own practice is really helpful, and I'm going to talk a little bit in a second about methods of self-appraisal and how we can monitor our own performance. And of course, professional development. Ultimately, continuous professional development is our responsibility as clinicians. We enter ourselves onto the register in full knowledge of the requirements that there are to us. And yes, our employer should support us in those, but it is our responsibility to make sure we do it and not theirs to chase us up on it. So being responsible for your own professional development is a really important part of individual clinical governance. So just to look a little bit more at methods of self-appraisal and the things you can do about it, things that you can do to identify your strengths and your weaknesses. We've talked about peer review and asking your colleagues. Audit is a really useful way of appraising yourself. And an audit doesn't have to be complicated. You could just be looking at how often you make sure you're greeting your patients appropriately. So saying hello and introducing yourself, or do you just tend to rush through it? Things like that. Patient feedback is something that the NHS certainly recommend you do at least once a year to get a snapshot at that moment in time at how happy your patients are. And as an employer, potentially, or at least a senior member of staff, you've got to listen to your staff. And that doesn't necessarily mean just what they're actually telling you. Listen to the undertone of the practice. How happy in general are the people that are there? Because they might not tell you directly, but the atmosphere of the practice can tell you a lot. Make sure you're looking at current evidence and literature to make sure that you're matching up to that. When we appraise ourselves, we have to have a standard to set ourselves against, and if we're always setting ourselves against the same standard year in, year out, then we're unlikely to be improving. We'll just be staying the same. So current evidence and literature and guidance can really help us with that. Do complete significant event analysis, and whether that be in its traditional sense that we talked about earlier or incident reporting. It's a way of learning from our mistakes or things we did really well. Listen to patient complaints. It is horrible when people complain about you. It will happen. They're not always justified complaints, but it makes you reassess, and that's not a bad thing. Your reassessment might come out with, actually, no, do you know what, I don't think I did do anything wrong, and I'm comfortable with what I did. Or it might come out with, well, actually, I've never thought about it that way. I've never realised that what I say or what I do could affect a patient like that, so I'm going to change. So patient complaints are horrible, but deal with them appropriately and you will learn from them. And the last is something called a SWOT analysis. SWOT stands for strengths, weaknesses, opportunities and threats. So say, for example, you've got a new guideline that's been put into place. What were the strengths and weaknesses associated with that guideline? Are there any opportunities to make it better? And is there anything associated with the implementation that could cause a danger, hence the threat? And SWOT analysis can be really useful as a quick way of just structuring what you're wanting to say in this method of self-appraisal. So there's lots of things we can do. Some things you will automatically do. It's quite natural for me, for example, to go and speak to a colleague and say, oh, I had this feeling and I'm just not really sure it went very well because of A, B and C, and that feels quite comfortable for me. Whereas I'm probably less likely to do a SWOT analysis. But everybody has their own methods and things that work well for them. So look at things that work well for you and try and do it on a semi-regular basis. As part of a bigger organisation then, there's also responsibilities towards clinical governance, and to kind of group them and to make a snapshot of them. What we're really looking to do is to establish a culture of quality improvement within the practice or the organisation. Not just staying the same, but always striving to be better. And if you think about the GDC standards again, patients always come first. And in first instance, do no harm. So if we're always striving to improve, then we will meet that standard. There is nothing wrong with it being related to aspects of dentistry which can make the practice more profitable. Doing an audit on time management, say, with the intention of, I think we're wasting time, we're losing money, that's fine. As long as it's not, we're spending too long doing things that you actually need to spend that time on. You know, maybe there's a lot of downtime, maybe there's not a lot of FTAs, things like that. So there's nothing wrong with wanting to make your business profitable. That's fine, as long as quality of care doesn't also slip in the process. And it doesn't really make sense for that to happen. Patients will pay for good quality care. They won't be happy to pay for rushed and rubbish care. And if they think that so-and-so down the road is more up to date than you, then they'll walk and they'll go to so-and-so down the road. So quality improvement can improve the profitability of your business, and there's nothing wrong with that, and don't be scared of that. So I hope you've got a better understanding of what clinical governance is now. There's quite a lot of references on the last slide that you can look into if you want to do any further reading, and the websites I gave you at the start as well could also be quite useful. What I really hope is that you're not left with this "why bother with any of it" attitude, because nothing ever changes. Apathy gets us nowhere. And sometimes when we've been doing the same job for a long time or been in the same role and we just don't really enjoy it, we spend a lot of time moaning about it, but doing nothing to make it better. Clinical governance is how you make it better. Speaking to people about it, auditing it, appraising it, making sure that you've got the time and the means by which to make it better. All these things are clinical governance. And if I can get rid of this, "oh, it's just me, I can't change anything" attitude, then we've done everything that clinical governance hopes to do. It's basically a long-winded way of saying your opinion matters and you can do something to change it. And I know that probably sounds a bit preachy, but I've spent a long time in my previous career being with people who didn't like their jobs but never did anything about it. And we're lucky that we're in a clinical setting and that we have something like clinical governance to help us improve our careers and our employment and our general enjoyment of our job. So that's us finished with this session. The next piece of SDL I want you to do is to go on and look at regulation of clinical governance and how it is regulated and what happens when it goes wrong or what happens when people don't follow it. So you'll find that on Blackboard as well, so you can now continue on with that piece of work.